MDT improvement programme. The multidisciplinary team, and particularly the multidisciplinary team meetings, have been absolutely transformative for the treatment of people with cancer. And I'm old enough to remember a time before we had MDTs, although we used to have clinical pathological conferences. But the formalisation of this process and the setting up of MDTs has been fantastic for driving up the quality of decision making for people with cancer, and for making sure that clinical teams can come together in an effective way to plan care. At the same time, we have created something of a mini industry and a little bit of a self-regarding bureaucratic process in some instances. And there is no doubt that multidisciplinary team meetings very often consume very large amounts of very important time of people working in NHS, clinical and other professionals. And just before the pandemic, we published a set of guidance for how to streamline MDT working, to try and make sure that we were reserving the energies of people in MDT meetings for thinking about the cases that really needed discussion, and taking out those cases that could be managed in a much more routine and protocolized way. And I think that has had some impact in helping to streamline MDT working, but there is the timing of it, in as much as it came out just before the pandemic, and the way the world has changed in the last couple of years has meant that I think there's a lot more opportunity to take this forward. And obviously, particularly one of the things which has changed is our ability to work remotely and to run MDTs in formats like this across a Teams meeting, rather than all having to sit huddled in the same room gazing at an X-ray screen or a microscope together as we used to do. So technology has helped us in huge ways to make MDTs more functional, but at the same time, it's also expanded the numbers of people very often who come into MDTs. And what we're anxious to do in thinking about how we make sure that our cancer services are performing at the absolute peak of what they can do, is to think about ways in which we might alter and improve how MDTs handle the people they're looking after, how we streamline the processes, how we make them as effective as possible, and how we really make sure that we're making the best possible use of everybody's very valuable time. Because as everybody is keenly aware, the one thing we don't have a huge surplus of in the NHS is professionals. Our workforce is continuously under strain, and the demographics of increasing cancer incidence and prevalence mean that we all have to work harder and harder to look after the increasing numbers of people who come through. And of course, the numbers of people being referred in on urgent suspected cancer pathways have gone up hugely as well, even while the number of cancers has gone up at a slower rate. So there are lots of good reasons to take a careful look at how our MDTs are performing. And the people on this call, you've been handpicked for your enthusiasm and interest in looking at ways to potentially transform the way your particular entities are working. So thank you very much for the interest and for the variety of applications that we had come through for this. My colleagues in the NHS England Improvement Team and the National Cancer Team are keen to work with you, and the purpose of the session today is to look at what we can all do and to learn from each other as to what works well and what's a difficulty. Many of the things which I think frustrate us in MDTs probably are common to different organisations, but very often people have found solutions that other people haven't quite thought of yet, or have done things in ways that other people haven't quite come to yet. So the purpose of this is to be as interactive as we can possibly make it, despite the fact that it's all a virtual meeting, to share solutions, to share ideas about how to streamline the process as much as we possibly can. And as I say, most importantly, to make the best possible use of your valuable time. So having said that, I hope that you have a really interesting and productive session, and we'll hand over now to the rest of the team.
Thank you, Peter. That was really helpful. Really good introduction for us, and we'll hear a bit more from Peter as we come towards the close of the session. Welcome, everybody. My name is Nick Holding. I am Head of Improvement with the elective team, sister team, the Emergency Care Improvements team, and the guys in the elective team have brought me in off the subs bench to come and help facilitate and host these sessions for us. And this first one really is all about welcoming you in, as Peter described, and giving you a bit of an introduction to to the Cancer MDT improvement program. And as Peter said, it will be interactive, lots of conversations, but a little bit of show and tell as well, and to give you a bit of background to the program. So packed agenda, and just if we just move on to the next slide. So we want to hear from you guys as well. So after I've done a little bit of the usual kind of housekeeping, we want to get you guys to come up onto the screen or open your mics and just introduce yourself. So we'll go through each of the trusts individually. So I'm giving you a bit of advanced warning here that we're going to come to you and just a quick 2 minutes, say who you are and from which organisations you've come from. Then we'll throw over to Alison and Robin, who are going to give a bit of more of an overview of the programme and some of the outputs. I think what we're going to do in between that session there is going to run a quick Menti. It wouldn't be a Teams meeting, would it, if we didn't have a Menti session? So we always have to include a bit of Mentimeter to get your thoughts and observations on what you want out of this particular programme as well. Have a bit of a Q&A after that, short period of time for Q&A if you have any. And then we'll go into some of our key speakers today. We're going to hear from Alex Graham, a colleague that I've worked with closely over the last few years around evaluation and how we can evaluate the work that we do, something we're not always that good at, in understanding what impact we've made. Leading on from that, we've got Tim Windsor-Shaw, who's going to talk about some of the QI methodologies that can link into this program and how we can really understand change and improvement from a methodology perspective as well. We're going to hear from Ben Lamb from BART, who's going to talk about some of the challenges with MDT improvement. And then hopefully Peter's still around in the office. He's going to be able to come back later on and just wrap things up for us. So yeah, packed agenda. We're going to be tight on time, so we're going to move through reasonably quickly. Just moving on to the next slide, we've got a few housekeeping rules, and I'm not going to go through all of them. We're all used to the kind of environments that we're working in now, but it's the usual. Cameras on where possible. I'd say go on mute unless you're speaking. That helps sort of avoid any embarrassing background conversations that might get picked up. Active participation, please. You know, we all want to be involved in this work. You've all taken the time to join us this afternoon, but also giving that time for other people to speak and have that sort of active listening. Use chat respectfully, the chat function, adding comments, observations, thoughts, questions if you feel you need to, and keeping that curious mindset, really, that open-minded growth mindset around how we be curious about asking our questions and about other people's different perspectives. And then where we believe there are some follow-up commitments, this is about how we stay true to the commitment of this group and this program moving forward. So if that's okay with you, we'll help sort of move through. So I did say we're going to do a little bit of a Menti. I'm going to flick through to the Menti screen now. So I want to get you, if you can get your phones out, or if you've got another screen that you can access, you can either scan the QR code, or if you use menti.com and enter the code 74300127. I don't know if anybody has got that from the team has got that, pop that in the chat as well. That'll be great. Just to help people click on the link, but I'll give you a few seconds just to log on to Menti. There should be a little thumb sign. Yeah, somebody's already done that. If you can click the thumb sign when you join, just so we know that you got there. How many people got on the call? We've got 60 people on the call, so we're expecting a good response from this survey. 2 quick questions I think we've got on the survey, so it won't take long. Yeah, lots of people still joining. Excellent, thank you very much. Okay, so I think with that we're going to move on to the first question, please. I think Crystal's got control of the Menti. Okay, so really simple question. What is it you're hoping to get out of this program? This has been put on by the elective care improvement support team for you, which is really important they understand and we understand what you want to get out of it. So really nice to see that straight away about how others work and how others run their MDT, about how we learn from each other. Good practice, sharing experience, that networking is really important. I think one of the things we often talk about is how do we create these networking opportunities without us having to travel all over the country and sit in the same room together. And I think we're finding better ways to do that through Teams and other online platforms. see if others, that's a really open-minded and humble way to see if others are doing it better and how. Really keenness to learn from others. Shared learning, excellent. So we'll be able to capture all these, and I think this should stay open for a bit longer. So this will be really helpful, and I'm sure the team will draw some themes out of this, which will almost certainly inform some of the future meetings. I know that they're not mostly planned out, but I think there's a few gaps still in the agendas on future meetings. So I think they'll give them an opportunity to respond to your thoughts here. Great, so that's 43 responses. If we move on to the next question. Importantly, we often ask this question: what don't you want from this program? We often ask that first question, but sometimes it's like, what don't you want? Because it's important for the team to understand this as well. So yeah, vagaries, criticism, limited engagement, great. Lack of support for change, yeah, too much extra work. Exactly. Yeah, I think how do we incorporate this into what we do already? Yeah, this is really helpful. This is really helpful because I think this element of, if you thought you were going to come along here and be told what to do by a prescribed solution, it's really helpful to get that reflection that that's not what you want, and that isn't what you're going to get through this program. You'll hear from lots of interesting people and hopefully be inspired and connect to other people, not to have an improvement. So yeah, and again, we'll hopefully touch on that later on, or we will touch on later on through the evaluation and the QI methodology about how we can learn to demonstrate improvement. Tokenistic engagement, thank you very much. Yeah, really good. So this will stay open, and you can keep on adding to this as we go. But that is really, really helpful. So thank you for engaging in that work as we get started. So I think at this point I'm going to hand over to Alison and Robin, and they're going to do a bit of talking, and I can take a bit of a sip of water, ready for the next session. Guys, over to you for a few minutes, then we'll have a little bit of a Q&A afterwards, if that's okay.
Thank you, Nick. Robin, are you joining us?
I am, yes. Hello. Hi, everyone. So my name's Robin Cupforth. I'm a performance manager in the NHS Cancer Programme.
And I'm Alison Paul, Head of Improvement for the Elective Care Improvement Support Team. So welcome everybody today.
And we're just going to go through some of the aims and outputs of the programme as it stands. So the main aim of the programme is to provide a structured and supporting learning environment to help you achieve effective and timely MDT meetings and decisions. I just want to emphasise, following the Menti exercise we just did, the programme is self-directed. We won't tell you what to do. We won't tell you how to do it. Obviously, there is national guidance out there that can help with things such as MDT streamlining. However, we very much want this to be focused on what you want to achieve and how you want to achieve it, and we will support you to do that. And we will equip you with some knowledge and some confidence to hopefully facilitate the changes and improvements yourself. And the main output will be felt, hopefully, in the MDT itself. It will be the improvement. And all the members of your MDT, your supporting staff and your patients should realise a benefit from the work that you're doing. So this is a very simple overview of the programme. So the programme itself is 19 weeks long. So we're obviously starting today and we'll finish on the 13th of June, which will be our handover event. And over that 19 weeks, you can decide how you spend your time and how you divide that time up. But there are some set points. So we have a number of learning sessions. These are going to be sessions where MDTs who have already made improvements to their meeting and to their practice come along and share with you their expertise and their experience. And we have 4 of those learning sessions in total. One based on protocolization and streamlining, another on inter-provider communication and processes. The third is on preparing for an MDT, and the fourth is on communication and leadership. In between each of those learning sessions, you will be expected to meet with your coaches, and I'll come on to coaches in a little bit further. And before the handover event, you're going to repeat your self-assessment, which you've hopefully already completed by now, and that will help you to assess your progress along those 19 weeks. So in terms of that handover event on the 19th of June, we will expect you all to have implemented a change in the way your MDT operates, and it can just be one change, or it can be many. That's up to you. As I mentioned, we want you to have repeated your self-assessment to help you review the impact of that change. And we'd also like you to produce a poster detailing what you did, how, and the impact of that change. And everyone will be presenting those posters during that handover event on the 13th of June. Now, in terms of coaching, every team has 2 coaches assigned to them, and these coaches all work in NHS England, and they will be in touch to introduce themselves and organise a meeting after this session, so that you can introduce yourselves and get to know each other. And the role of those coaches is to support you to work towards change. So again, they won't tell you what to do, they won't tell you how to do it, they won't criticise you for doing anything. They will ask open and challenging questions to prompt you all to take actions, to reflect and identify solutions to any challenges. And as I mentioned earlier, you will meet with your coach after every single learning session to reflect possibly on that learning session, and your progress so far and your plans. And we really do ask that all team members join the meetings with your coach if possible. So you're going to hear more from other speakers this afternoon about where you can start, but we do recommend starting small, or at least starting to focus on one thing rather than a lot of things. And you might find it helpful to create a really simple plan to help you over the next 19 weeks. And if you're struggling with that, your coaches can help you to identify actions and how you can approach delivery. So please use them as an asset. There is also additional support available. So we have set up a workspace on Future NHS, and you should have all been invited to that already. And that workspace will hold the recordings of all the learning sessions. So if you're not able to make any of the learning sessions, a recording and the slides will be on there. Any resources we share as a programme. There will also be discussion forums on there, so you can interact with other MDTs on the programme, share your challenges, share your solutions, feedback on the learning sessions and what you may have learnt. And you also have your senior leadership executive support. So if you remember right back to when you applied for the programme, you would have had to nominate somebody senior to sponsor you throughout this programme. Utilise them, keep them updated on your progress, and escalate to them any major barriers that you come across. And if you have any urgent issues that might affect your participation in the programme, please contact your coaches. Okay, I think we're moving on to a bit of a Q&A. We have a few minutes now if anyone has any questions about the programme itself, about the structure, or the coaching that I've mentioned.
Thanks, Robin. It's really helpful. Anybody want to pop their hands up if they've got any questions, or pop it in the chat? If we haven't at this stage, I'll give you a couple of seconds to think about it. If we haven't, we can move on. No questions at the moment. All good. Brilliant. If you do have any other questions as we go on, just pop them in the chat and we can pick them up as we go. So did give you a bit of a warning at the start that we want to do some introductions. So thank you for bearing with us. I wanted to give that bit of a sense of where we're at from Robin and Alison first. So just a couple of minutes from each organisation. We're going to go in order as it is on the screen here. So Barnsley, you get the lucky job of going first and leading the way. And everybody else can just prepare themselves with their little 2-minute pitch. Literally just who you are and introduce who's joining from your organisation. So who's on the call from Barnsley?
I'm on the call from Barnsley. My name is Catherine Patrick. I'm Macmillan Lung Cancer Nurse Specialist, and I'm also uniquely the lead for our lung MDT. So I believe on this call I've got Dr. Caroline Lee, who is our oncologist. I believe I've also seen Lorna Olsop, who was our MDT coordinator, and Katie Hopkins, who was my service manager. I apologise from a respiratory consultant point of view. We're very, very thin on the ground. We've got a lot of sickness. So they've been unable to attend this introductory meeting. And Dr. Raw, our radiologist, is unfortunately on annual leave, but hopefully they will be engaging in the later sessions. So from an MDT, we've seen quite an increase in numbers that we're discussing in our MDT due to the introduction of the lung health check programme here in Barnsley. It has dramatically increased our numbers. So we really want to look at streamlining, ensuring that we are discussing patients correctly, effectively, safely, and make sure that we have all relevant information ready for MDT discussions. So that's one of the aims of us coming on the programme.
Brilliant. Thank you, Catherine. And I think it's a really helpful note to slot in this point. The recording will be... Somebody just joined. Can you go on mute? Thank you very much. Just to note that the recording will be available afterwards. So if anybody can't make it today, they'll be able to pick up later on. Thank you very much for that. Brilliant introduction. Thank you. Medway, do you want to go next?
Hello there. I'm William Garrett. I'm a colorectal surgeon from Medway and the colorectal MDT lead. I'm also regional bowel cancer screening program director, although that's not relevant really for this. Various of my colleagues, I'm hoping, are joining, but I'm actually on leave at the moment. So I'm not at work, I've rung in remotely. So I'm not completely clear who's with us amongst my other colorectal colleagues, radiologists, and of course, clinical nurse specialists. The main thing that I would like to try and iron out here is probably pointing out to everyone, if they don't already do it, that the best way to make your actual MDT run as well as it can is to have done a pre-MDT beforehand, but I'm sure this is all being discussed later on anyway. And secondly, as has been touched on with some of the guidance that you've already expressed, simple etiquette, like everyone being engaged, so that, for example, when you start discussing a patient and then you say, can we look at the imaging then? And from a remote source, a colleague might say, which patient are we talking about, for example? And I think this is one of the things that we will touch on in terms of keeping it snappy and as organized and simple as possible, if you see what I mean. But I'm sure there's lots of other stuff that's going to be coming out of this. I don't think I've got anything else particularly to add at the moment, unless any particular questions that you think I should say.
No, thank you, William, and thanks for joining us on your day off. We really appreciate that. We're going to move on to Blackpool. Anybody from Blackpool?
Thank you very much. Yes, my name is Jawad Islam. I'm a consultant urologist and MDT lead here. My team includes radiologists, cancer specialist nurses, and pathologists. I'm not sure who's on the line and not. So basically, the idea of coming in this program is that our MDT has really soared up. I mean, we're discussing around 50 patients in 2 hours, and I want to see the opinion of improvement team and my colleagues to how to cut it down and what are the different methods used. Thank you very much.
Thank you. Yeah, really, really helpful, and welcome everybody else from Blackpool. Just down the coast, Liverpool.
I'm Adam Beatty, and I'm the Cancer Transformation and Ops lead at Liverpool Women's. So we're here not just for the Liverpool Women's element of our MDT. It's a specialist gynecology cancer MDT hosted by Liverpool Women's. So our group it consists of representatives, consultants, CNSs from across Cheshire and Merseyside that join this MDT that we do together. That includes Countess of Chester, Clatterbridge, Warrington, Liverpool University Hospitals Group, Whiston, and the Wirral, and a representative from our Cancer Alliance, so that we can all kind of engage and move forward together. Of course, that can be quite a complex thing. What we're looking for is, improvements to improve that kind of technical remote style MDT to make it as smooth as possible. Thank you.
Brilliant. Thank you, Adam. Sounds really interesting. I'm sure over the course of the the programme, will share some of the thoughts from how you've learned how to work that particular wider model. So really interesting. Thank you. Down to Worcester.
Hi there. So I'm Laura Throssell. I'm one of the service improvement managers for cancer services at Worcester. I'm joined by my colleagues Claire Hibbert, who is the Deputy Cancer Services Manager, Dr. Bart Kurek, who is our oncologist for our urology MDT and our Deputy Clinical Lead for Cancer, and Ahmed Kadira from the urology team. We've kind of put forward two of our MDTs, being urology and upper GI, at least for the initial sessions. Some of the focus we wanted to look at was that for urology especially, we have a high volume MDT, so the structure of that, MDT etiquette, and some work on the process of recording MDT outcomes. Interestingly, everything that everybody suggested that they'd like to focus on, I think is relevant for us as well. So obviously some common themes early on. We haven't got representation from our upper GI team today, unfortunately, because it clashes with the clinical commitment after MDT. So interesting to hear that the sessions will be recorded and the coaching sessions will kind of come in between those as well for availability. Thank you.
Yeah, exactly. Thank you, Laura. Yeah, really important that there are some consistencies as well in terms of what people want to gather. So thank you for that, Laura. Okay, we're going to go to the greatest city in the country, Wolverhampton.
Indeed. Hi, everyone. My name's Olumide Finran. I'm from Royal Wolverhampton NHS Trust. I'm a gynae cancer surgeon. I'm also the lead for the MDT. I think I've got here quite a few of my colleagues. I've got our oncologist consultant, Dr. King. I've got two of our radiologists. I've got a pathologist.
Look at that. I'll big them up as well, and they're frozen. See if anybody comes. Anybody else from Wolverhampton can jump in.
Hi, I'm Ramani Jawad. I'm one of the consultant radiologists
Hi,
at
thank you.
Newcross, Wolverhampton. I work with MIDE at the gynae MDTs. And essentially, I think, we're kind of similar themes with everyone else. We're just really here to try and streamline those MDTs and bring down the numbers. So for me personally, both urology and gynae MDTs, particularly urology, again, we have very large volumes. So I would be interested to look at it from both perspectives.
Thank you, Ramani, and thanks for jumping in. I think we've got. Do you want to jump back in, Alamidi?
Yeah, sorry, just the signal.
No
So Ramani's said exactly what I was going to say, which is just find a way of streamlining. I think years back, quite interesting to hear what Mr. Lamb would say, because I think I listened to him a few years ago when he was talking about the MDT, and we've been looking at ways of making it more efficient, including our CNSs, getting rid of things that are not necessary, reducing the workload, and also the timing. We seem to have our MDT at a very, very odd time in the evening, and we're trying to work towards, making it more within working hours so everyone can contribute. But yeah, looking forward to getting a lot out of this. Thanks.
Thank you very much. Thank you both. Up to Yorkshire, Sheffield, please.
From the best city in Yorkshire, from Sheffield. So I'm Ahmed Al-Mukhtar. I'm a hepatopancreaticobiliary surgeon and a lead for retroperitoneal sarcoma neuroendocrine tumor. So our aim, more or less, touched by all other team. I think we are all in the same boat. We are just aiming for much better sale, hopefully at the end of this course. And there are quite a few of my colleagues, they are in the process of joining, and we have a few of the CNS. They are also in the group. So I hope that we will have very good, fruitful outcome out of this. Thank you very much.
Thank you very much. And then last but by definitely no means least, Warsaw.
Hi, I'm Huda. I'm a nephrology consultant of all things, being roped into sorting out the rapid diagnostic clinic and I consented stupidly. So, but I say this, but I'm dual accredited. I think general medicine is wonderful. It's a very good one, general medicine clinic. It's a very good learning clinic. So we have set up a teaching clinic for Rapid Diagnostic Clinic. So there are trainees, and we are just at the beginning of this. So it's about how do we optimize this across both us and Wolverhampton, actually, because the service is sort of combined, or maybe overlapping is the right thing to do to say. And also set up an MDT across the multiple specialties, because anything can come in that don't necessarily fall under my expertise either as a nephrologist or as a general medic.
Brilliant. Thank you very much. I think what you just touched on there is the opportunity, I guess, through this program where there'll be some formal element to it, but some of the informal elements where, just from a geographical perspective and an organisational perspective, there's some links between yourself and Wolverhampton, and there'll be some others that in terms of content or subject matter that you may just reach out to each other more informally and just start to learn through some of the natural networks that exist. I think that's some of the beauty of these kind of programs, that isn't too tightly structured, that enables that for some of that to happen. Thank you very much for that. I thought that was really interesting, really helpful, and just gives a sense of who's in the group and introducing you to each other. As we move forward, you'll start to build some of those relationships and some of those networks. So thank you. We're going to move on to the next section now with Alex. Always be really interesting. No pressure, Alex, but these are always interesting sessions from Alex. In between each of these, we'll have a bit of a Q&A opportunity. If there is any, as I mentioned before, pop them in the chat if you want, and I'll pick them up from there, or just raise your hands after Alex and Tim when he finishes off afterwards as well. We can have a little bit of a session around any questions you might have specifically around evaluation and QI methodology. So, Alex, I'm going to throw over to you, and you can entertain the masses.
Thanks, Nick. Yeah, no pressure. Hi, everyone. So lovely to see you all on the call. The team have asked me to come along to talk to you guys about evaluation, and great that this has been part of the first sort of introduction to this session. Evaluation is something that should be thought about at the very beginning of a programme and an intervention. And I've got some slides that I'll kind of talk through what it is and how we can do it most appropriately. And maybe you'll be able to apply this into some of your working MDTs or some of the other programmes that you work on within your organisations. So could I have the next slide, please? I'm not sure who's driving. Apologies. Thank you. So what is evaluation and how can we define it? So it's a planned investigation of an intended change or intervention. So that's when we actively want to change something and investigating the impact and effect that that's had. Why do we do it? It brings structure, transparency, and it can give weight to any claims that you want to make or you do make about the change that you've been trying to achieve. Generally, it's better if it's done by someone that's not involved in a project, just to bring that level of independence and less bias. We wouldn't want to mark our own homework, essentially. So if you can have that level of independence, that's great. But again, depending on the complexity of the programme itself. So the word itself can sound a little complex, but it can be small or large and applied to any project. It's good practice to learn from outcomes, and I'm emphasising when I say the word learn. So evaluation is done to learn and to inform, and it's part of that cycle of improvement. So it's good practice to learn from outcomes and to test whether or not your intended outcomes have happened or not, and if not, why. And as projects get bigger, naturally they'll need more resources and specialist people that are conducting the evaluation. But it doesn't always need an expert. And I won't claim to be an expert, but generally anybody can do it. So often something that comes up is understanding kind of economic impacts of change, which I'll say up front is very, very difficult and takes years and needs specialist methods, which can be costly. But often this isn't needed. The evaluation generally just needs to be proportionate to what it is that you're doing. And then finally, for this slide, it's not research, audit or analysis evaluation. So these are all different things. We use similar methods in each, but the lens we take is very different because we're looking at kind of different things. If I could have the next slide, please. Thank you. So The next few slides will just touch on the different parts of evaluation. So that's your initial scoping and project initiation phase, designing and feasibility testing, data collection and analysis, and reporting and dissemination. And I am going to rattle through these slides quite a bit. I know I've got quite a bit to get through, but hopefully these slides will be shared afterwards and you can use these as much or as little as is needed. So if we just move on to the next slide, which touches on scoping and project initiation, and I've used a logic model to kind of talk through this, and I'm not sure if any of you have been familiar with the rapid improvement offer that has just finished. Actually, it was an offer to improve to support urgent and emergency care within various acute trusts across the country. And a logic model is just a really great tool to set out how we plan and what's involved in all of our deliveries and our programs. And you can also, and this also fits with teams. So if you have your cancer MDT, you could essentially map the different inputs, deliverables and outcomes, and then national goals or benefits across that logic model. So it just really gives you the overall view and vision of what it is you're doing, why you're doing it, and what you want to achieve. So it provides you with a rationale for an evaluation and the ability to explain what it is that you're trying to change and why. Additional to logic models, there are things like theories of change. You generally would have hypothesis, driver diagrams that should then be done in line with stakeholders. So it's important to remember that we're evaluators, not necessarily designers of that project. So it's really important for us to clarify the why behind we're doing that project, hence the use of logic models and theories of change and things like that. In your scoping and project initiation, it's really important to engage your stakeholders. This sometimes can be really difficult, but it's important to get that input from interested parties just to clarify that what you've got in these logic models is correct, so that you know that they're agreeing with those outcomes, because that's what we're agreeing to deliver. And in your assumptions section at the bottom there, these are the things that you put in to say with your stakeholders that these are the things that we're assuming that is in place in order for us to achieve the outcomes by doing some of the deliverables in that place. So you need to get buy-in early on to ensure that participation, especially from your stakeholders. If I could have the next slide, please. Thank you. So this graphic here is taken from the Magenta book, and I've got some links on the end of this slide deck that point you into sort of various documents and places where you might be able to get a little bit more information for evaluation techniques if that's of interest. But the Magenta book is civil service guidance, and it provides an overview of different design aspects to any evaluation, and it goes up and down in complexity from process evaluation to value for money. I'll just talk through some of the probably most common design areas in evaluation. So developmental is often when there's no rationale for the intervention, and you're almost acting as a critical friend to the programme where you're constantly growing and developing the intervention. Process, this is particularly relevant to some of the stuff that I guess you'll be doing. So measures, implementation and delivery. So has what you planned to do been set up as you planned, and is it operating as you planned? And how have people adapted and changed from what we planned to reflect what their context is? So a question you might ask there is, how can we make our MDT better? An impact evaluation, slightly more complex, so it's outcomes focused, or thinking back to that logic model. So you should have data underpinning those outcomes. Did the change we predict happen, and what was the scale of that change? And so therefore, question to demonstrate that is around what demonstrable impact does the MDT have on patients and NHS services? And then the economic and value for money, and I touched on this earlier, needs a lot of other conditions to be in place, things like time, equipment, costs. And doing this type of evaluation retrospectively is almost impossible. It should be embedded via data at the beginning by collecting time and cost throughout the intervention to then be able to find that monetary value at the end. Can I get the next slide, please? Thank you. So these are some of the methods. Methods relates to the specific approach to data collection and analysis and the reasoning for this. So the choice of methods will be based on the questions being asked and robustness around the questions. So, for example, if you want to find patient outcomes from a clinical intervention, then a standardised patient-reported outcome measure can be used. So I'm sure you've all heard of qualitative versus quantitative information. So your qualitative is more about understanding reasoning as to why someone's doing something or why they're behaving a certain way, often described as your softer. I say that with sort of speech marks either side. So the softer outcomes, behavioural, culture, often leadership and development, things like that. And quantitative is around activity data. So ambulance conveyances, quantifiable survey data, numerical data metrics, and which of these are we looking for changes in, and how can we attribute changes in data? And that attribution piece is often quite a challenge to get true attribution within some of that data for interventions, which is why using a mixed methods, both qual and quant, is great. You kind of really backing up some of that quant by having that descriptive, experiential, qualitative. And I get the next slide, please. Thank you. So data connection analysis. This is probably the heart of evaluation. I think a lot of colleagues I'll chat to tend to think that this is what evaluation is, full stop. But it's the data collection side that is the heart of it, and lots of rules around it. You can't generally just go around collecting, you know, an nth degree of data. Generally, simply talking to people is collecting data, and we have to gain permission for this. Things like experimental designs require ethics approvals, which can take a long time. There needs to be an ethics committee, but often this isn't the case. And often with things like survey data for small internal teams, this isn't necessary. But testing data goes back to the importance of stakeholder engagement. If your participants and or stakeholders aren't on board, it's really difficult to distribute surveys and things like that. And I'm sure there's colleagues on the call that have held surveys and delivered surveys and things like that. Response rates tend to be really, really low for surveys. And if you've not got that relationship with stakeholders, it can be incredibly difficult to push the responses for that surveys. And if you've got no data, there is no evaluation. So the planning phase, it really does rely on that. Analysis is a really important part of evaluation, but is dependable on what data you have and can be quite obvious and specific to your project. There are various types of analysis, so things like thematic analysis for large pieces of text involving coding of transcripts for qualitative data. And then for quantitative, there are things around significance testing and statistical tests, but often that's the very complex phases, and we don't necessarily use that regularly in specific internal NHS evaluations. Often simple analysis, such as finding averages in answers and cross-comparing data to understand difference. It really doesn't need to be so complicated and statistical. But the Magenta book, as I mentioned earlier, is really helpful for types of data collection and analysis. Next slide, please. Thank you. So reporting and dissemination. So the main purpose of evaluation are learning and accountability, like I mentioned in the beginning, and to be beneficial, the findings of the evaluation need to be disseminated in the best format to the right decision makers. Now, in our team, we make use quite a lot of Power BI dashboards. So we provide an overview and comparing quantitative data via the use of their dashboards, and they can be shared and disseminated very easily via links, hyperlinks, which is a really inclusive, interactive way of presenting data. But again, having that initial conversation with stakeholders and asking the question why they want this data and in what format is really important at the very beginning. And I mention again, the purpose and point of evaluation is for learning and to help other programs be informed as to how what gaps are within the initial program, and therefore how we need to develop to inform for future. And then I've finally finished with a quote there on this slide: to ensure the department's approach to evaluation is transparent, we'll continue to publish evaluation activity. So everyone that tends to have been involved with your evaluation and who's participated in any field work that you may have done to collect that data collection even, they have a stake in that evaluation. So I always tend to try and share any report that I've created as a result of that field work with the people that have been part of that. They have a stake in it, and often they're quite interested to know that something has been done significantly with the input that's been provided from them and the time they've given to do some of that work with you. And then next slide, please. I won't spend too much on this because it's a very text heavy slide, but I've put it in there because of the purpose of time, and it's just quite a helpful checklist for establishing that you've done relevant things in order to create that evaluation successfully. And if these things aren't in place, then we'll end up with the less robust findings. And it won't be surprising to hear that a lot of these things are to do with good project management. And what I will say is project management is key with evaluation, and if you've got those teams within your organizations, to marry those up with anyone that's doing the evaluation is hugely important. And as I said, from the very beginning, so you've got that layout and understanding of the world and the program at the very beginning. And then the next couple of slides, well, the next slide is the final slide, which I mentioned earlier, that just has some links on there. If you're interested in evaluation and want to learn a little bit more about that, this has been a little bit of a whistle-stop tour, but if you have any questions now or later, I can drop my email in the chat, and feel free to reach out and make contact. So yeah, thank you for listening.
Thank you, Alex. So yeah, we have got a bit of time now. If anybody has got any questions, burning evaluation questions, they desperately need to ask right now, or pop them in the chat or pop your hands up. I'm not going to let you get away with it. I'm going to ask. I've got a question if I can take chair's privilege, but I won't jump in. I'll let Matt jump in first.
Well, I have the same opinion, Nick. I'm not letting Alex get away with it. So one of the things we've heard already from a couple of the MDTs is obviously that they're trying to improve the time and the length of their MDTs, and I guess people probably aren't currently recording how long their MDTs are taking exactly. They probably know it anecdotally, but have you got any advice about how people might deal with that if they're looking to evidence that they're improve the time of their MDT? What we could do, and is there like minimum amounts of data we might need to do that?
I think it depends on what data is readily available in the organisation. So what I would first say for any MDTs to create, what I mentioned at the beginning of that talk, is around is the logic model. So what are some of the outcomes that it is that we're trying to achieve? And they don't necessarily have to be outcomes that are specific metrics, so movements in data. It can be improvements for patients, for example, or something that's more outcome focused instead of a metric, and then ensure that each of those outcomes are underpinned with either a qualitative metric or a quantitative metric, so that you know exactly what data it is that you're looking to make changes or movements on, and ensure that you have a baseline at the beginning of your measurement or a baseline after. Or you could use year-on-year data, so say it's busy around winter, for example, in various metrics for obvious reasons. You'd compare 4 weeks this year with 4 weeks at the same time period last year, so ensure that there's some kind of comparative analysis, but obviously if that fits with what it is that you're trying to achieve. So it's why I think it's really important to just lay out that plan in the logic model in the very early onset, to ensure that you're doing what it is that you've said to set out to do, and you've got some data that you can readily collect. Or do you need to create data sets to then do that before? So I guess it's kind of it's all in the planning, I think. Hope that answers the question.
Yeah, that's very helpful. Thank you.
Great question, man. I think it speaks a lot to the session we're going to get from Tim as well in a short while, about how we understand continuous improvement and how that links very nicely with evaluation. If you get the right metrics early on, you understand how you're progressing, what you're doing, and then you've got some nice metrics there that can lead through into the evaluation. You're trying to find the evaluation metrics afterwards and do some retrospective. So I suppose my question, Alex, was in terms of a little bit linked to that, is maybe your experience of some of the pitfalls around evaluation, some of the traps that we might fall into, particularly around a little bit of confirmation bias around choosing or following a measurement that confirms an existing opinion, perhaps. What would be your advice in terms of for the teams about how that we get true evaluation, and how do we avoid some of that confirmation bias that may exist in terms of at the start of a program like this?
Yeah, I think engaging with your stakeholders and ensure that when you are mapping out that stakeholder list of who it is that you're kind of serving and who's involved with the program and who's kind of going to be on the receiving end of what it is that you're delivering. Ensure that you're questioning with your stakeholders and ensure that you're engaging them in some of the outcomes that you're setting out for the deliverables, so that you've kind of got peer reviews with those stakeholders in the outset. And so that I would suggest if you're actively involved in delivery of the program, then ensure that there is a level of independence in designing any evaluation and doing any data collection, and especially with analysis. If you are someone that's delivering the program, or if you're a clinician that's got a strong stake in the outputs of that evaluation, then generally don't do it yourself. If there's somebody else in the organization or a colleague that's there that's able to check your work, if there's nobody else, or that's able to do it independently, then great. But it is really difficult to avoid that, especially with the limited resource in the program. But peer reviews are great. And there is internal resource within NHS England, and I'm always here. So any questions, and I know the colleagues within NHS England, there's an evaluation function, a community of practice. So if anybody's interested and does have any active questions and would like to join that community of practice, then again, reach out and I can pinpoint you into to that direction. The team are always helpful. So yeah.
Great. Thank you, Alex. Really, really helpful. So as I predicted, really useful little session there on how do we understand evaluate. It's such an important part of any program that we are discovering more and more the value in just looking back and understanding the impact before we move on to the next thing. So yeah, thank you for that, and hopefully people have taken away some key points from that. But as you said, I think you mentioned it already, these slides will be available on the Futures platform, and obviously the recording will be available if you want to go back and listen again to that session. And as you mentioned, and Tim's already started his session in the chat, so this sort of links us nicely onto the session around QI methodologies and around how do we understand the more sort of continuous improvement approach to change from the outset, and how do we learn through the work, and that reflects some of the changes. So I'm going to hand over to Tim, and he can lead us through QI methodologies, and particularly from a continuous improvement perspective. Tim, over to you.
Thank you very much, Nick. So I've only got a couple of slides here, and I'm not going to teach you about QI methodologies in the short time we have. But just to say, obviously improving something sounds like you could use common sense to do it. And I guess that the real trouble with that is that it involves a lot of communication. All of the work that we're doing here, and I can go to the next slide now, is in fact the one after that. That's the one. All of this work requires a lot of engagement with other people. The actual doing the work itself tends to be quite a short or a small part of the overall endeavour of applying an improvement intervention and then implementing it into the wider system. So in NHS England London, we've put together a methodology for the way that we would like to work based on some successful examples from other trusts and organisations. And we are also working with NHS Impact on this. But that's all big stuff. And what I would say is, if you're going to do something, try and do something that's not very risky, that's quick, and then move through the steps. Do something else that's not very risky and is quick, and you can get some results and build on those results. So I'll just run through our methodology that we use. First of all, it's getting together and deciding on what area you're going to focus your efforts. And in this case, I think that's already been done. We're looking at MDT effectiveness and efficiency. Then you have to understand the situation. And by that, I mean, actually delve into what is going on at the moment. You might need to, for example, do a sort of process map of how MDTs or your MDT functions right now. You know, do you get together, people put together a patient list? Who does that? How do they do that? Which patients go first? Which goes at the end of the list? Do you do easy to difficult, difficult to easy, or do you not know? And what impositions are there on doing it that way, whatever way you're doing it? You know, what system things come into effect externally and internally in the way that you have to do these things. Why are you doing it, you know, after work rather than during working hours? Is it because people are not willing to give up their time to this? Do they see this as an add-on to their normal work? What is that? Are there other systems pressures there doing that? So you might need, when you're on this second phase, you might need to bring in some other people, some specialist people who work sort of peripheral to your team, who are dependent on your team. If you're trying to work to relieve pressures in other areas of the hospital, you might need to have some people from those areas and say, well, you know, you're trying to relieve areas, the pressure on us, but actually you're sending us the wrong people, and then we have to go through a whole process of sending them back. So it might not just be getting through people, and I'm sorry, I'm looking a bit dark on this camera, so I do apologize for that. It might not just be getting through a number of people, but it's the quality of the work that you're doing as well. How well do you do that? And of course, I'm sure as you know, clinicians and people in the MDT, you want to make sure that that work is as effective as possible. You just do not want people to have to go through the MDT decision-making process, and then the wrong outcome comes out the other end, pops out the other end for them, and then they have to go through it again at the next meeting. That's something I'm sure you're all aware of. So you're looking at quality as well as the timing of this. And you're going to have to look at what sort of measures you can get from that. So having current measures, baselining where you are, trying to look at the SAP, the standard operating procedure that you're using for your MDT. That might be a process map, or it might just be a list of instructions. It might be who attends, how regularly do they attend, who can't attend. All this information can go in, and you need to collect that, and you need to have a team of people that are willing to work together on this and are focused and are clear in their minds about what they're doing. Then you can start to hone in on a particular aim, and you can really be clear about that aim. And the point of that is not that you are not clear, it's just that you want everyone else in your team to be clear. It's a bringing together. It's, as I say, communication is the basis, the fundamental of all this work. It's a foundation. So it's important that you write down that aim and agree it and try and put it in words, because when you're trying to decide what you're going to measure, if that aim does not link to that, you know you've got a problem. Or if the measures that you're doing are not adequate to fulfill the demonstration by evidence that you've achieved that aim, then you need to go back to look at your key metrics to do that evaluation. And it doesn't have to be complicated. In fact, as I've put in the chat, the different types of measures that you use for research when you're looking at ethics are very different to the measures that you're using, for example, for judgment. You know, is this MDT performing? That's a different measure to the measure that you're using for quality improvement. What you need to do is see a change that's significant enough to say, okay, that intervention is worth doing. And when I'm saying intervention, I'm meaning a process intervention, not intervention for the patient. And that brings me to the patient. The patient needs to be involved in somewhere in this thing. Whatever you're doing in the MDT, you need to have some clarity that patients are on board with that they're seeing some benefit from doing that their information is being used effectively and appropriately. So you need to have some stakeholder engagement and make sure that someone is looking at that, who you've got involved in your team, and whether they should be involved or whether you should have somebody else as well. So I'm saying all these things as though they're gospel. They're not gospel. You can take check them out. You can see where it's failed or where it hasn't failed in other organizations. A lot of these things, though, are things that have been tested, and I've put something in the chat about learning how to improve from the Health Improvement Agency. What was it called? I forgot. It's in there anyway. You'll be able to see that. And they give some good evidence for saying it's not just about the tools that you use, it's about your approach. You need to model certain behaviors in order to make this possible. You can't improve a system if you are not a self-improver. You can't improve a system if you don't engage with other people. And you can't improve a system if you don't reflect on what you're doing and what you have done, and reflect on what other people are saying rather than continually interrupting them. And you can't improve a system in doing what I'm doing now and saying, this is how things go. You know, there is no gospel about this. You have to be flexible and you have to work with people. Working with people is the key to doing this. Phase number 4 is testing and refining ideas. And that's where you use these as low risk as possible and as quick a test as possible to see whether it's actually improving things. So you could just try doing the MDT in a slightly different way once, reordering the patients that are assessed during the MDT, or having some information just sent to you in advance in text form or email form and not having those people present, or having them sign off in advance on other possible agreements. I don't know what they would be because I don't work in MDTs. You do, but you will have other people that you can consult who will also be able to help with this. And it's a mass endeavor. And by that I mean I don't mean lots and lots of people have to be involved, but you can use the wisdom of crowds to help you solve a lot of these issues. And by testing things that you think, well, that should work, that should improve it, just do a quick test. If it's not risky, try it once. If it doesn't work, note it down and then move on. That's the thing. There is no such thing as failure in this. There's only such things as a mistake of not learning from failure. So every failure that happens is a thing that you can learn from and say, well, that didn't work and we thought it might. So now we can move on to something else. I mean, I'm telling you obvious stuff, but you have to have psychological safety to have this area of testing where things can fail, but you need to have that within your team and a certain degree of trust. The last 2 sections there, implementing change and spreading change, that's where project management really has to kick in. So there you have to treat it seriously as a project. You have to make sure people are properly trained and that you have the support of the staff who are going to implement it, and that it's going to be rolled out efficiently and effectively with all the support that people need. And a good way to ensure that it's sustainable is to spread it. So spread it to other teams as well. You can then get feedback from them about how they've done it, and that will help you too. So yes, what's a key message we need to be allowed to fail sometimes to be able to improve is correct. Alison's put in the chat. You need to be able to fail a lot of times, actually. So that's why it has to be low risk and quick. And that's part of the testing cycle. But before you get to this testing cycle, the connecting, the understanding, that all has to go in there. If we can see the next slide, please. This is my last slide. You just move on. So this is from our case study template, and this takes you through the 6 phases. You can see at each phase some of the questions, the prompts that we say to people. Look, on the first stage in the connecting, make sure you've got the right people involved. Just jot them down. What are the assumptions that you're making about things? You know, can you or can't you do this, and why not? And then be clear about the problem area on focus, and make sure that you've got a team together and that they know they are part of that team and that they are committed to helping, and so on throughout the 6 areas there. So you'll have these slides, you can have a look at that and you can take what you want from them. But this is we think is a good way to move forward. It's not too complicated, And if you do get stuck, you can actually look into in more detail using tools on the final slide here, which are underlining, if you can move to the next slide, these are tools which you can use to help improve your systems, and hopefully it should be a continuous improvement because it's never done, and things change all around you, so you're always having to adapt. But underneath these are the improvement mindset that you have to have and your team has to have, which is the way of engaging, the way of communicating, the way of reflecting, the way of listening and thinking together. Affinity diagram is a great way to start off this whole thing, and I would recommend that you look at that. Write down all the problems that you think might be happening with causing the issues with the MDT timing, and that would be a great start. And you might need to get other stakeholders involved. You don't know, really. It might be porters need to be involved. I don't know. Or it might be record system, IT people. I don't know who it might be. It might surprise you who you need to get involved. But this is a simple model, and don't get bogged down with too many things about ethics and evaluation at this stage. But evaluation and measurements, as Alex has said, are very critical because you need to be able to evidence this so that you can spread it. And that's all I have time to tell you today, but I wish you the best of luck.
Tim, thank you very much. Excellent, excellent, really helpful advice and some great links there as well. Yeah, I think that keep it simple is so important in improvement, and fail forward fast is the, once you've got your teeth in, you can say that quickly. You start to learn that idea that you can just try something out and give it a go. It hasn't got to be fully formed before you do. So thank you for that, Tim. Really well described. Anybody got any questions for Tim following that session? No, again, we've got the slides will be available afterwards, and the coaches, as the program progresses, I guess that's what, there's a lot of support through the program in helping you to possibly make some of these short, quick tests and giving you some of that confidence to be able to do that. So yeah, some great links to pick up on. So I think next we're going to hear from Ben Lamb. I think we really sort of pick up some of the challenges and the opportunities around MDT improvement, and picking up from Ben's experience. I'm not even going to start to list all the titles that he's got there. You can see on the screen that how much Ben is involved with this type of work. Ben, over to you. We don't have any slides. I don't know if you have any slides, or are you just going to talk through
thanks, Nick.
this section?
I'm going to try and share my slides. Is that visible to everybody?
It's visible. It's just not in slideshow at the moment, but
let me get into slideshow. How's
there
that?
There we go. Perfect. Fantastic. Brilliant. Over to you, sir.
Thanks for the introduction, and thanks to the previous speakers. And listening to what you've all been saying, there is going to be a bit of repetition, and I promise I hadn't had an advanced preview of your slides, but hopefully that means what I'm going to say isn't too outlandish if it's been said by other esteemed colleagues. So I'm Ben Lamb. I'm a urologist in London. I'm an MDT enthusiast, and I've been working in MDT development for about the past 15 years. And so I thought I'd just share with you something about the challenges that are facing us when we're trying to improve the way we work with our MDTs. There's some disclosure and acknowledgements to my colleague Tyana Sukup in particular from Imperial College. So I think we heard from Peter right at the beginning that MDTs are regarded as the gold standard of cancer care, and really originated, I think, in wide practice in the UK, and have now spread across the world to developed countries and developing healthcare systems as well. And there's pretty good evidence that working as an MDT, looking after our patients in a collaborative way, reduces variability in treatment, improves the timeliness of diagnosis and treatment, adherence to guidelines, and there's some studies even suggesting that it helps increase patient survival. There's also growing evidence of other indirect benefits, so improved workforce well-being, education and training, Although they are resource intensive, as we've heard, they do represent, when they're running well, good value for money. And patients that we've worked with also find them very reassuring to know that there's a team behind them. However, as we've heard, and as we know, we're under increased pressure. And this has been a theme in a number of different important policy and research documents over the past 10 years, with a call to drive improvement, focus on good clinical decision making, focus on efficiency, using validated tools to do that. The good news is the tools are available. And as we heard in the previous talk, there are methods and there are programs like this to help support people to improve the way their MDTs work. This is a list of some of the tools that me and my colleagues have been working in developing, from surveys to observational methods, interventions like checklists that can be used in MDT meetings. And there's a growing body of evidence to support these. We also know how they can be applied. So they can be applied routinely in the MDT meeting, routinely preparing for the MDT meeting, and then also perhaps periodically to try and improve the way we work through audit and reflection with our teams. We know as well that it's really important that this is a team-driven approach and it's very reflective rather than top-down. So that begs the question, why are we here? Why are we here 30 years after MDTs were started? If we've got we've got some resources, why is it not working? My colleague Tyana Sukup is an implementation scientist, and she's mapped the Medical Research Council definition of complex interventions very closely onto interventions to try and improve MDT working, such as streamlining. I think we have to face the fact that MDTs are very complex processes, and there is not going to be a simple one-size-fits-all answer. And if we look at the definition from the Medical Research Council, to tackle a complex intervention such as MDT improvement, we have to recognise and understand the complexity of what we're going through and what we're asking of ourselves. So where do we start? Can we look at the scientific literature on MDT improvement? Well, we're currently undertaking a big international systematic review looking at the literature on MDT improvement. We're going through nearly 1,000 international peer-reviewed publications, and I'm pleased to say the UK is the leader on research into MDT working. But if you drill down into it to look for particular evidence for specific interventions, for example, streamlining, we found only 4 published papers in the whole history of the world on MDT streamlining. So there really is a bit of a vacuum at the moment when it comes to the knowledge base on which some of these interventions are based. Part of the problem is there's this, what's known as the translational gap, where the time it takes from translational research to get into routine clinical practice can be as many as 17 years. And what we need to do, programs like this, I think, are very well placed, is to try and reduce that gap. So to put learning into routine clinical practice much more rapidly by systematically evaluating what we're doing, as we've said, sharing interventions, sharing those that work and those that don't work, to try and generate that evidence and that knowledge so that we can all improve our practice. So we know what some of the challenges are. We know what some of the options for improvements are, but what are the challenges we might face with MDT improvement? I picked the brains of some of my colleagues who are also involved in MDT improvement from across the east of England, London and other places. And if you take a few seconds here just to read some of these comments, I think they'll probably ring true to many of you. Problems with job planning, problems with training and improvement methods, older, more mature team members perhaps being resistant to changing culture, with younger, more junior team members perhaps being nervous of innovation, nervous of change and doing things outside the MDT meeting. There's now a reduced oversight compared to perhaps 10 years ago with peer review. So there's less accountability for MDTs to demonstrate continuing performance, continuing improvement. So these are just some of the things, but they rang true to me, and I'm sure they will be familiar to many of you as well. So what are we to do? Well, I thought I'd put together a few of the thoughts that I'd had about challenges and approaching MDT improvement to try and get the best of the resources, the best of the time we have available, and the biggest impact of our interventions. You probably heard the parable of the elephant being assessed by various blindfolded people, and to one person it seems like a snake if they're holding the trunk, seems like a rope from the other end, or a wall from the middle. And I think the same could be said with our MDTs. It's really important, as was said before, to get engagement, not just from your MDT lead, but from all members of the MDT. And my colleague, Dr. Sukup, has found that even something as apparently simple as what is complexity, what are the complex cases, you get very different answers depending on who you ask. So the engagement and the input from each of the members of the MDT is going to be crucial to understanding what the issues are and driving forward change. What we did in Northeast London to kind of kick off our program was to stage an engagement event, which was facilitated by Yappa Creative, a really innovative kind of coaching company. We had over 60 delegates, from the chief executive to clinicians to patient representatives, and we were able to start the day brainstorming. We then translated these brainstorming, you can see the kind of handwritten notes, into specific work streams with specific deliverables that people would put their name to. So it was really good to not only to work out what the priorities were across the region, what the resources were, but who the enthusiasts are, and identify those champions who have a keenness to take these things forward. I think once you've got engagement, you have to keep engagement, and you have to build a sustainable system to deliver this improvement. So what we've done is we've developed a steering committee with a clinical lead, with a program manager. We've got enthusiastic clinicians, and there was a mention earlier of involving IT experts as well, which I think is like extremely important given our reliance on technology and IT. And I think much of the future will lie in using technology to improve our efficiency and take away some of the drudgery of MDT related tasks. For short-term projects, we've then got different short-term working groups, task and finish groups, to tackle particular problems like technology issues or streamlining, so that then these shorter projects don't, you get less fatigue and attrition with your longer standing committee members. And as was said earlier, it's really important to be able to feed back and keep stakeholders informed of what you're doing. So the steering group, as well as providing oversight, it's also an opportunity for those who are running improvement projects to feed back to those team members to let them know what's going on. Understanding the context is also really important. So getting a real understanding of, within a trust or within a cancer alliance, where are your MDTs? Who are they? Do you have an MDT for every tumour type? Do they link in with other hospitals, other trusts? Who's the lead? I mean, when I started in Northeast London, we were given a list of MDT leads that was about 15 years out of date. So actually understanding who are the people you need to engage with is a really important starting point. We tried to map out, when we were thinking about streamlining, how are we going to deliver this intervention? Where do the interventions need to be, inserted into the way our MDTs work? We presumed all MDTs would kind of work in the same way, but when we actually looked into this in a bit more detail, we found different tumour types have differing and often very complex flows of work, from perhaps more peripheral hospitals through to specialist MDTs. And so I think, had we failed to understand that, then our interventions would have fallen flat in many cases. Take the low-hanging fruit. So I think work with enthusiastic people, go for the easy challenges first, so that you get maximum impact for your energy and for your resources. It comes down to people working together, and we are all human. We get tired, we get jaded. So go with the easy things first. Don't attack problems that are intractable. And I think you have to accept that we won't be able to solve all the problems with all MDTs through these approaches, but being able to recognize that, I think, will help you get maximum impact for your energy. Think about the future as well. So not just how do we improve MDTs now, but when we're handing over to, junior nurses, doctors, MDT coordinators, when we, mature and retire, how do we equip them to take over from us? How do we give them the skills? And I've helped develop a couple of courses, both with University of Suffolk in the east of England, with the Cancer Alliance there, upskilling MDT coordinators who we know suffer from high turnover, low retention rates, to give them the skills and the abilities they need to do their job really well and improve their confidence. And we've just concluded our first 2 cohorts of our MDT lead development program in North East London, working with some excellent colleagues from Living Potential Consulting, Prostate Cancer UK, Imperial College, to try and upskill our MDT leads, not just in chairing and running meetings, but also thinking about longer term quality improvement and improving the way we work. And then finally, linking into what was said before, share your findings. There's a real lack of published research on MDT innovation and improvement compared to other areas of healthcare. We need to know what works, but we also need to know what doesn't work, so that people aren't trying things which are may inevitably not work and not lead to improvement. Greater Manchester have published a great piece of work they've done on MDT reform and transformation. Colleagues from North Central London Cancer Alliance have published their hybrid toolkit for hybrid and online MDT meetings. And in the healthcare journals and other literature, there are other articles that are published, spreading that word and sharing our learning with each other, which I think is something that's going to be really important going forward. And I think this program is a really good way of doing that. And then hopefully we can, reduce that knowledge gap and more rapidly share useful information with colleagues. So MDTs are huge. I think we often underestimate the scale of MDT working. Every cancer patient, pretty much almost every healthcare professional involved in cancer care works in an MDT. And it can sometimes seem like an insurmountable challenge. But I think similar to eating an elephant, not that I've done that before, but apparently one bite at a time, which I think is probably a good message to take away. Thank you.
Ben, that was fantastic. Thank you so much for that. Really helpful to draw on your learning and experience in this work. I think it just connects this program and demonstrates the value and the importance of it, as you touched on there. And I think that sounded like a challenge to me, to someone out there, to how do we learn better, maybe publish some of the work that you end up achieving through this work. Thank you for that. Kathy's got a question in the chat. She's asked, are the training programs online and available?
Yeah, so I think as Peter mentioned earlier, we are moving to far more online working, which does allow us to engage with more people over big distances more easily. So our MDT Leads program has been exclusively online, and the latest edition of the MDT coordinators training has also been online. So I think that does improve engagement. Yeah. Fabulous.
Thank you. Hopefully that answered your question, Kathy. Thank you, Ben. Great session, and I'm sure you'll stay connected to this program through this work. So really appreciate you giving us your time this afternoon. Just before I invite Peter back, just to close the session, just let you know that Crystal has popped some links in the chat back through to the Futures platform, and where there'll be all the recordings from today, slide decks, and also the discussion forum as well, and other materials as the program goes. So make sure you save those links in your favorites that you can access whenever you want, and I'm sure the team will add to that as they go. Ben, I just saw a question in the chat. I'm going to throw to Peter in a minute. If you just have a look at that, if you don't mind, and just see if there's a question that Jessica has got. Guys, thank you very much for your time today. I found that really, the time's flown, and we're nearly 2:30 already. So I find that really interesting and useful. Hopefully you have too. First of many sessions that we'll sort of link together. Next one, from memory, I should have written this down, I believe is the 28th of February, and on a Friday morning, that's 10 o'clock in the morning, which will be the next session. I'm going to throw to Peter to give him the last 5 minutes of the session, just to close things off for us before we head off into the afternoon. Peter, can I invite you back to close the session for us?
Thanks very much, Nick. That's been really interesting set of presentations, and it's brought back to me a number of things about MDTs. First is that every MDT is a bit different. I know from my own organisation that every tumour type MDT functions a bit differently. And like everything we do, this is about the people. And a number of points that clearly emerge from this. Number one is MDT coordinators are absolute gold. And the more we can do to reinforce to our MDT coordinators how valuable they are to the running of the organisation, the care of the patients we're looking after, the better. And although there are challenges of turnover, actually when they're enjoying their job, they're valued and they're appreciated by the rest of the team, people will stay doing these things for a long time, and that's absolutely golden because they make such a huge difference to the care of patients. Secondly, the chairing of the MDT is clearly a crucial activity, and making sure that as the chair you are engaging the whole team, bringing people's views in, making the thing interesting is really critical, and making sure that we're upskilling our chairs and encouraging people to do this really important work is incredibly important. Personally, as a clinician, I find MDT meetings incredibly rewarding. It's a great way to discuss ideas, work out what's best for particular patients, and also to bring yourself up to date and to hear new ideas from different members of the team. So there are huge advantages, both in terms of the day-to-day management of people, but also for our education and our development as clinicians and others. So all sorts of benefits to be emphasized there. I think Ben made a very good point that we used to have a very regular look at how MDTs were functioning and their policies and so forth, and that as we've dropped away from the repetitive peer review programs, so that's become less frequent. And I would encourage people to wire in a regular review and a reappraisal of what goes on in the MDT, at least on an annual basis, and in some cases more often, and looking and reviewing how the thing is functioning, what's good about it, what's not good about it, is incredibly important. And it is something that has, as Ben says, has rather slipped in recent years, and particularly since the pandemic. So lots of takeaways. The streamlining of how we all work is clearly a big issue, and as the volumes and the numbers go up, working out how we can do this in a more efficient way, whether it's pre-meetings, whether it's protocolized to manage straightforward cases more straightforwardly. And lots of work also to do in making sure that how we record the outcomes of MDTs and some of the software systems that are out there, some of the electronic solutions to the management of information are also really valuable, and I hope we can share some learnings about those. So thank you all very much indeed for your time and contribution to this. I hope the rest of the programme will be really successful. I think this is such a key part of cancer care. It's absolutely integral to good quality cancer care. One of the things that we all know is that quality, like everything, is heterogeneous and variable, and the more that we can all do to make sure that the MDT teams are engaged, taking the right decisions, recording the information in the right way, and doing it as efficiently as possible, is all about delivering the best possible care to the people that we're looking after. So thank you all very much indeed, and I hope the rest of the programme is as stimulating as this first one has been.
Thank you, Peter. And that's us closed. Have a good rest of the afternoon.
Thanks, everybody. Bye-bye.